In the name of Allah. In this lecture we will study malaria. Malaria is a mosquito-borne infectious disease affecting humans and caused by parasitic protozoan called Plasmodium. We have 4 species of Plasmodium. The first one is Plasmodium vivax and cause benign tertian malaria. The second is Plasmodium ovale, which cause ovale or tertian malaria. Plasmodium malariae, which cause malaria or cotton malaria. And the last one, which is the most dangerous one, is Plasmodium falciparum, which cause falciparum or subtertian or malignant malaria. Geographical distribution. Plasmodium vivax most predominant in tropical areas. Plasmodium ovale also predominant in tropical areas. Plasmodium malariae present in temperate zones. Plasmodium falciparum present in tropical areas. No hosts except human. Human is the only host, although higher apes may harbor Plasmodium falciparum. Infective stage is sporozoite, which is present in saliva of infected people. What about mode of infection? How man gets infected by malaria? The first one is the bite of infected female Anopheles mosquito. It is the classic mode of infection and principal mode of infection. The second is blood transfusion, then contaminated needles and syringe, usually between addicts. Sharing of syringe occur between addicts and may cause malaria. The fourth one is congenital transmission, which is possible but rare. Infectivity of blood donors. Plasmodium falciparum is still infective for 1 year. Plasmodium vivax and ovale is still infective for 3 years. Plasmodium malariae is still infective as long as 50 years. When we study life cycle of malaria, we find that malaria parasites have 2 cycles during their development, which is called alternation of generation, and requires 2 hosts, which is called alternation hosts. Life cycle. Development of Plasmodium in infected human. Infective female Anopheles injects sporozoites in its saliva at the site of the bite. Then sporozoites can reach liver within 40 minutes through blood. Inside liver cells, sporozoite transformed into trophozoite. A nucleus of trophozoite divided into multiple pieces, and each piece take part of cytoplasm surrounding it, form what's called merozoite. Multiple merozoite inside hepatocyte is called schizont. Now we have liver schizont. What's the fate of this liver schizont? The fate is rupture, liberating merozoites, which invade RBCs. All liver schizont merozoite invade RBCs, except in case of Plasmodium vivax and Plasmodium ovale. Some merozoites is still dormant inside the liver and called hypnozoites. When activated later on, it will cause relapse. And what about merozoites that enter erythrocytes? When merozoite enter erythrocyte, it transformed into ring stage. The nucleus of merozoite become peripheral, and there is loop of cytoplasm and enclosing between this nucleus, which is called chromatin dot, and this loop of cytoplasm, enclosing between them a vacuole. So it looks like a ring. It is called ring stage. Ring stage feeds on hemoglobin and then transformed into trophozoite. Trophozoite has a nucleus, and this nucleus will divide it into multiple pieces to form a schizont. What's the fate of erythrocytic schizont? It ruptured, and all merozoites liberating from erythrocytic schizont invade RBCs. No merozoites from erythrocytic schizont re back to the liver. No, never occur. It invade RBCs only. And after several cycles, when hemoglobin is deficient, merozoite enter RBCs and don't transform into ring stage. It will form gametocytes, male gametocyte and female gametocyte. And now the cycle is ended in human. So in human we has two cycles, exoerythrocytic cycle or exoerythrocytic schizogeny, end by formation of liver schizont and rupture of liver schizont, and erythrocytic schizogeny, end by formation of erythrocytic schizont and rupture of this erythrocytic schizont. And these cycles are asexual. So the rule of man in case of malaria is, yes, is intermediate host. The sexual cycle takes place inside the stomach of the mosquito. When a clean female Anopheles take blood meal from patient, it will take all erythrocytic stages, ring stage, trophozoite, schizont, male gametocyte and female gametocyte. All stages are digested inside the stomach of the female Anopheles except gametocytes. By reduction division, female gametocyte become macrogamete and male gametocyte by exflagellation become microgamete. Union of macrogamete and microgamete will form zygote, and this zygote will transform it into a worm-like structure called ookinete, which penetrates the wall of the stomach to be beneath the basement membrane and transform it into what's called oocyst, and appearance of sporozoites inside this oocyst making it sporocyst. What's the fate of sporocyst? It will rupture inside salivary gland of female Anopheles mosquito. So now the saliva of this female Anopheles mosquito carries sporozoites, and this mosquito now is infective to man. So the cycle is called sporogony because formation of sporozoites occur in this cycle, and this is the sexual cycle. And now female Anopheles mosquito is the definitive host. There is some important definitions. You must know these definitions. Pre-patent period. What is the pre-patent period? It is the interval between inoculation of parasite and the time of parasites or appearance in blood smear. Incubation period. The interval between inoculation and onset of symptoms. What's pre-erythrocytic cycle? It is primary exoerythrocytic cycle or liver schizogeny. What is para-erythrocytic cycle? It is reactivation of hypnozoite initiates a secondary exoerythrocytic asexual cycle. This reactivation of hypnozoite is thought to bring about the relapse, which is characteristic for oval Anopheles infection. And in our book we have a table. It is important table. It is differentiation between the 4 species of Plasmodium. The disease is tertium malaria in case of Plasmodium vivax and ovale, quartum malaria in case of Plasmodium malariae, subtertium or malignant malaria in case of Plasmodium falciparum. Pre-erythrocytic cycle, it is 8 days in case of Plasmodium vivax, 9 days in case of Plasmodium ovale, 12 days in case of Plasmodium malariae, and 6 days in case of Plasmodium falciparum. What about incubation period? 40 days in case of vivax, 21 days in case of ovale, 28 days in case of malaria, and 10 days in case of falciparum. Para-erythrocytic cycle present with Plasmodium vivax and Plasmodium ovale, but absent in case of Plasmodium malaria and Plasmodium falciparum. Number of merozoites in liver schizont. It is 10,000 in case of vivax, 15,000 in case of ovale, 2,000 in case of malaria, but wow, it is 40,000 in case of Plasmodium falciparum. Erythrocytic cycle, 48 hours in case of vivax and ovale, 72 hours in case of malaria, 36 hours or irregular of falciparum. What about pathology of malaria? Symptoms of malaria are due to release of massive number of merozoites into the circulation after rupture of erythrocytic schizont. Infection results in production of antibodies against merozoites and schizont, and the activated macrophage help in destruction of infected erythrocytes and anti-coated merozoites. Enlargement of liver and spleen occur due to enhanced phagocytosis of remnants of ruptured erythrocytic schizont and debris of these schizont. Also, we notice that the color of liver and spleen become dark brown due to pigment. What about these pigments? These pigments are hemosiderin. It is a metabolic end products of heme part of hemoglobin due to digestion of hemoglobin as the ring stage feeds on hemoglobin. So pigments start to appear in the stage of and still present in case of schizont, still present in case of gametocytes. Malarial infection is associated with immune suppression and associated with hemolysis of infected and uninfected RBCs. Also in Plasmodium falciparum malaria there is adhesion phenomena. It is very important phenomena that cause malignant malaria. Merozoites of Plasmodium vivax and Plasmodium ovale are able to invade only reticulocytes, young RBCs. Plasmodium malariae are limited to old RBCs, while Plasmodium falciparum is able to invade all ages of RBCs indifferently. Natural immunity against Plasmodium species infection. Genetic and nutritional factors may offer a sort of immunity against malaria. Low level of iron and other nutritional deficiencies are additional factors that may provide a host environment in which parasites don't survive well. You know that ring stage feeds on hemoglobin, so poor RBCs making it to change or transform it into gametocytes, not to trophozoite. Absence of Duffy antigen in many blacks, resistance to Plasmodium vivax infection, as Duffy antigen facilitate entrance of merozoites of Plasmodium vivax into erythrocytes. Hemoglobin S in sickle cell anemia. Shape of RBCs and type of hemoglobin are not suitable for growth of Plasmodium falciparum. There is resistance against infection with Plasmodium falciparum. Deficiency of glucose 6-phosphate dehydrogenase enzyme give some sort of immunity against Plasmodium falciparum as the parasite needs its growth. Relapse. What about relapse? It is a famous question in oral exam. What about relapse? Relapse occur in Plasmodium vivax and Plasmodium ovale infection. This is due to presence of hematozoites in liver. What about recrudescence? All species may cause recrudescence, especially Plasmodium malariae and Plasmodium falciparum, due to persistent low-grade parasitemia due to incomplete treatment or failure of immune system to destroy the parasite. Anemia. In malaria, it is hemolytic anemia. Reticulocytes affected only by Plasmodium vivax and Plasmodium ovale. Old RBCs affected only by Plasmodium malariae. So anemia occurring by them restricted anemia. In comparison to anemia caused by Plasmodium falciparum, which affect all ages of RBCs, shows severe anemia. Complications. Plasmodium vivax, Plasmodium ovale, and Plasmodium malariae usually relatively benign, but in chronic malaria there is nephrotic syndrome. As the parasite produces increased amount of antigen, with antibodies it will form immune complexes. When deposited in the glomerular wall of the kidney, it activates complement and cause kidney tissue damage. Clinical picture. Incubation period followed by influenza-like symptoms. Then malaria paroxysm, which is called clinical attack, coincide with rupture of erythrocytic schizont. liberating in the circulation merozoites, toxins, and pigments. It includes cold stage, which lasts 15 minutes, followed by hot stage, which lasts from 2 to 6 hours. Then sweating stage, it is the end stage of this paroxysm. It lasts for malaria paroxysm attack recur at the following interval. In case of Plasmodium vivax and Plasmodium ovale, occurs every 48 hours, so it's called tertiary malaria. In case of Plasmodium malariae, occurs every 72 hours, so it's called quartan malaria. Plasmodium falciparum attack occur from 24 hours to 48 hours, it's called irregular or malignant malaria. Patients also complain from headache, fatigue, dizziness, anorexia, arthralgia, abdominal pain, diarrhea, and vomiting. There is anemia, there is splenomegaly and hepatomegaly. But between paroxysms, the patient may be tired, but otherwise feel fairly good. Malignant malaria caused by Plasmodium falciparum. It is the most dangerous type, may be severe and fatal. Paroxysms are less well defined and fever may be continuous or irregular. In non-immune, the primary attack can be fatal, whereas in endemic areas, in immune adults, it leads to parasitemia with no fever or illness. Recrudescence may occur up to 1 to 2 years, rarely longer. Complications of Plasmodium falciparum malaria. All complications arise from adhesion phenomena. What's adhesion phenomena? You must know that the parasite that inhabit RBCs, in case of trophozoite of falciparum and schizoid of falciparum, this parasite secretes a substance which represented on the surface of parasitized RBCs as a knob-like structure detected by electron microscope. This knob-like structure making RBCs to fuse with each other and to stick to the endothelium of blood capillaries of internal organs, leading to formation of clots and then decrease of blood supply, which may cause anoxia and necrosis of these organs. So there are multiple forms of malignant malaria according to the organ affected. The most important organ is the brain. So we find cerebral malaria. Signs of encephalopathy, meningitis, convulsions, and coma. The mortality rate is 20% with good medications. The second is the lung. Decreased blood flow in pulmonary circulation leading to pulmonary edema and difficult in. Also very important organ is gastrointestinal tract. Ischemia in capillary bed of intestinal wall occur. And there is acute hepatitis with enlarged tender liver and jaundice. There is dysentery, which is very similar to acute bacillar dysentery. There is cholera-like perfuse diarrhea, watery diarrhea, vomiting, dehydration, and muscular cramps. There is also algid form or algid malaria. It resembles acute adrenal insufficiency with low blood pressure, collapse, and peripheral vascular failure. Black water fever. It is called also malarial hemoglobinuria. Occurs due to repeated attacks of Plasmodium falciparum infection, and the trigger mechanism is irregular dosage of quinine with exposure to cold or exercise. Pathogenesis of black water fever, intravascular hemolysis of RBCs, hemoglobinuria, and renal failure that affects only non or semi-immune individuals. There is anemia, hemoglobinuria, jaundice, and this is autoimmune with development of antibodies against. And this slide shows that parasitized RBCs that carry trophozoite of Plasmodium falciparum and schizoid of Plasmodium falciparum will stick to the endothelial lining of blood capillaries, causing adhesion phenomena, and there is autoantibodies against RBCs, all RBCs that cause hemolysis and represented by black water fever. Also, there is a phenomena accompanied with Plasmodium falciparum or malignant malaria. It's called tropical splenomegaly syndrome, hyperactive malaria splenomegaly, characterized by the following: massive persistent splenomegaly in individuals living in endemic areas, a non-transient reduction in spleen size upon antimalarial treatment, lymphocytic infiltration of liver, anemia, and increased serum polyclonal IgM and antimalarial antibodies and complexes formation. Diagnosis. How can I diagnose a case of malaria? Clinical diagnosis: characteristic fever, enlarged tender spleen, anemia, microcytic hypochromic anemia, and leukopenia or pancytopenia. Parasitological examination via blood film. We have two types of blood film: thin blood film and thick blood film, stained by James or Leishman stain. Thick blood film usually done in case of survey for a huge number of patients, as we destruct stroma of RBCs, so we can detect infection by Plasmodium. But what about the species of this Plasmodium? I don't know. So I must make thin blood film to know the species of Plasmodium and the type of malaria. In blood film, when I examine blood film, I must differentiate between all erythrocytic stages of different Plasmodium species. So when I examine a case of Plasmodium vivax, I find that RBCs enlarged and rounded, while in case of Plasmodium ovale, infected RBCs is enlarged but oval. In case of Plasmodium malaria and Plasmodium falciparum, infected RBCs are normal in size and normal in shape. The first erythrocytic stage is the ring stage. Ring of Plasmodium vivax, Plasmodium ovale, Plasmodium malariae usually occupies 1/3 of the RBCs and consists of chromatin dot, one chromatin dot, and loop of cytoplasm enclosing between them a vacuole, empty vacuole. But ring stage of falciparum has many characters. The first, it is smaller than them. It occupies 1/6 of the size of infected RBCs. The second, it is multiple infection. I mean, I can see more than one ring in infected RBCs. 2 rings, 3 rings. The third is presence of 2 chromatin dots in one ring. You know that the ring consists of chromatin dot loop of cytoplasm, but in case of falciparum, there is 2 chromatin dot. And the last feature is that ring came to the periphery and chromatin dot come attached to the membrane of RBCs, parasitized RBCs, so giving aquily appearance. Trophozoite. Trophozoite of Plasmodium vivax is irregular in shape, vacuolated, so I called it amoeboid in shape. Trophozoite of ovale is oval and compact. Trophozoite of malariae start by eye bird appearance, then become basket shaped, then become band shaped. Trophozoite of Plasmodium falciparum is compact and I can't see it in peripheral blood due to adhesion phenomena. Now we may notice dots inside parasitized RBCs, and these dots take a name of scientists that discover them. Schaffner dots in case of Plasmodium vivax and Plasmodium ovale, and these dots due to degeneration of RBCs or due to that RBCs become old. When humans become old, appearance of wrinkles in the face occur. And when RBCs become old or degenerated, there is dots inside parasitized RBCs. It is called Schaffner's dots in case of vivax and ovale. In case of malaria, it is called Simon's dots. In case of falciparum, It's called Mohrer's clefts. Schizont. Schizont contains merozoites and contains pigments. In case of oval, it has fimbriated edge. In case of malaria, merozoites are arranged as a rosette shape. In case of falciparum, no schizont can be detected in peripheral blood due to adhesion phenomena. What about gametocytes? Gametocytes usually circular, and nucleus of female gametocyte is condensed on the periphery. Nucleus of male is present in the center. But in case of Plasmodium falciparum, it is banana shape. So when I examine blood film for malaria, I can detect all these erythrocytic stages, except in case of Plasmodium falciparum, I can detect two stages only, ring stage and gametocyte. Malaria pigment is hemozoin. It is a remnant of hemoglobin that was digested by Plasmodium parasite. Schaffner's dots, Simon's dots, Mohrer's clefts are called stippling, and it is the degeneration process occurring in Plasmodium infected RBCs. What about other methods for diagnosis? Provocative test, Ascoli's test, by injection of adrenaline solution subcutaneously to stimulate the parasite to appear in peripheral blood in chronic cases with no parasite in blood. Also, cold shower may be useful. Serological diagnosis, detection of circulating parasite antigen using monoclonal antibodies, or detection of antibodies in serum using ELISA, using indirect fluorescent antibody, using indirect heme agglutination test by ELISA or by PCR. Treatment. We have many lines of treatment. The first one is radical cure drugs, drugs acting on very erythrocytic and tissue forms, and so it prevents relapses, like brimaquine. The other line is suppressive drugs, act on erythrocytic stages to terminate acute attack, but relapses may occur, like quinine, like chloroquine, like mefloquine. The other line also is gametocidal drugs, which destroy gametocytes, so prevent infection of mosquitoes, like brimaquine, pyrimethamine, and proguanil. The other also is sprontocidal drugs, arresting sprogony, like pyrimethamine and proguanil. The last one is causal or true prophylaxis drugs, drugs acting on pre-erythrocytic stages, thus prevent infection of RBCs, like pyrimethamine and proguanil. Treatment of drug-resistant cases by prevention and control. Treatment of cases, as the cases are source of infection for mosquito. Mosquito control. We will study mosquito control in details in chapter entomology. Chemoprophylaxis to persons who will travel to endemic areas. Vaccine. Many methods of vaccination against malaria are now under investigation, aiming to prevent any infection or to alleviate clinical picture or to stop transmission to mosquitoes. None has been approved as effective vaccine for human. It's under study. Babesiosis. Babesiosis is a disease transmitted from animals to human, so it's called zoonotic tick-borne disease. Tick, as the definitive host is tick, hard tick. Causative parasite, Babesia bovis and Babesia microti. We have two species of Babesia, Babesia bovis, also called Babesia divergens, a parasite of cattle in Russia and Europe. It infects mainly immune-compromised patients and usually fatal. Babesia microti, a parasite of rodents in North America, self-limiting disease in normal individuals. Life cycle of babesiosis. Mode of infection through the bite of hard tick. It is the classic mode of infection through bite, so it is called anterior station transmission, and through blood transfusion. Hard tick bite man and introduces sporozoites in its saliva to the blood of this man. Sporozoite enter erythrocytes and then transformed into ring stage, which is the diagnostic stage. Ring stage making by budding, reproduce by budding, reproduction leading to formation of merozoites, and then erythrocyte full of merozoite, it will rupture, and liberating merozoite will invade another RBCs. Ticks acquired the organism during feeding on an infected individuals. In the tick, the organism divides sexually in the gut and migrate into the salivary gland. So infection is anterior station transmitted through bite. Clinical manifestation may be asymptomatic or give malaria-like picture with hemolytic anemia but with no periodicity. Fulminant disease that may end fatally. This occurs in immune deficient patients and in splenectomized patient. Diagnosis: blood film, pear-shaped or rounded parasite inside RBCs found in pairs united at the pointed ends, giving Maltese cross appearance, and is characteristic for babesiosis. No stippling, no pigments. Serology also can diagnose this case, and PCR also can use in diagnosis. Treatment by clindamycin plus quinine. Prevention and control. Treatment of cases, as cases are source of infection to heart tick, and control of. In our book we have an important table also, differentiation between Plasmodium and Babesia. In case of Plasmodium, man is intermediate host. In case of Babesia, it is a zoonotic disease, man is accidental host. In case of Plasmodium, transmission by female Anopheles mosquito. In case of Babesia, transmission occurs by hard ticks. In case of Plasmodium, exoerythrocytic cycle occurring in the liver, but in Babesia, no exoerythrocytic cycle. In case of Plasmodium, different erythrocytic stages can be detected in blood film, like ring stage, trophozoite, schizont, and gametocytes. But in case of Babesia, merozoites multiplying by schizogeny, leading to formation of schizont and liberation of merozoites due to rupture of this schizont. In Plasmodium, there is stippling and pigments. In Babesia, no stippling, no pigments. In Plasmodium, sexual cycle takes place in female Anopheles, but in Babesia, sexual cycle takes place in hard ticks. In Plasmodium, relapse occurs with Plasmodium vivax and Plasmodium ovale, but in case of Babesia, no relapse. In case of Plasmodium, periodicity of fever occurs in all species of Plasmodium except Plasmodium falciparum. In case of babesiosis, fever is continuous or irregular. So we can notice that the differential diagnosis of Plasmodium falciparum is Babesia. Plasmodium falciparum causes black water fever, and babesiosis has another name, red water fever. Plasmodium responds to antimalarial drugs, but Babesia no response to antimalarial drugs. In case of Plasmodium infection, there is no immunity after recovery. In case of Babesia, there is solid immunity after recovery, but cattle remains carrier. Now we reach the end of our lecture. I hope that you understand this lecture.